My name is Mallory, and I'll be performing a physical assessment on my patient, Mr. David Hall. Mr. David, if you have any questions while I'm performing my assessment, please just let me know. I'll answer them the best of my ability.
Yes,
Okay.
ma'am.
All right. First of all, we're going to start with the face. Checking for symmetry. Look at me, please. Symmetry. Look at me with straight head straight. There you go. Symmetry. Everything looks good. Inspected for nodules, lesions, nothing there. Now we're going to inspect your scalp. You can go ahead and chin to chest, please. Inspecting scalp, looking for anything, any nodules, lesions. Hair is evenly distributed, which is also awesome. You can look back up at me. We're going to go through the maxillary and frontal sinuses. Just let me know if you feel any pressure or pain. All that looks good. Good deal. We're going to check your TMJ. I'm going to get you to open and close your mouth, assessing for any clicks, okay? Close it for me. Open. Close. Good. Open. Close. Okay. Good. Also, we're going to inspect your nose, looking for any nodules, lesions. All that looks good. I'm going to check your patency. I want you to include one nostril, breathe out of the other one. Okay? Go to the other one. All right. Looking at your eyes, looking for any drainage, crust, all that looks good. Eyebrows, hair is evenly distributed, eyelashes are distributed evenly. Look at me, sir, please. Pupil size appears to be 4, so that's good. I'm gonna look at your conjunctiva, sclera, irid, and cornea. Okay. I'm gonna checking for what we call perla. Okay. So look at me straight. Good. Eye looks good. Sclera is white. Irid is blue. All that looks good. No crust. Nothing like that. Going over to your ear. Palpating for any lesions, nodules. Looking inside the ear. No drainage. All that looks good. Going over to the other right ear, looking for any drainage, lesions, all that looks good. We're going to do what we call the whisper test. I'm going to occlude one side of your ear, whisper something in the other. You tell me what I say.
Football.
Basketball.
Basketball.
Okay, good deal. All right. Also, I'm going to inspect your temporal arteries. Palpating them, making sure everything's even, regular. All right. All right, I'm going to get you to clench your teeth for me. Clench them. All right, looks good. I want you to, that was cranial nerve 5. We're going to go into cranial nerve 7 now. So smile for me. Frown. Raise your eyebrows. All right, puff your cheeks. Close your eyes. Good deal. Show your teeth for me. Good deal. All right. Going back to the eyes, I'm going to get you to stand right here. I want you to read. This is the Snellen eye chart. This is what we use to test visual acuity. I measured the 10 feet. Back up just a tab right up to that table. That's the 10 feet mark. Read which line you can read for me.
ED. F. CZP.
All right, I want you to close your right eye. Tell me which one you can read.
EDF. CZP.
Okay. Close, do the other eye for me.
EDF. CZP.
All right. So according to the chart, he scored what we would say is a 20-30. So that's great. You can have a seat right here for me. All right. Now we're going to check cranial nerves 4, 6, and 3 with extraocular movements. So what I'm going to get you to do is I'm going to put my fingers in a certain direction and you just follow with my eyes, okay?
Okay.
Tell me when you see them. See my other fingers.
Right there.
Good deal. All right. We went through our perla, so that's good. Went through the eye structures. Went through the ear. Nose, Alright, now we're going to inspect your mouth, mucosa, teeth, gums, tongue, soft, hard palate, pharynx, and uvula for me, okay? Alright, open your mouth wide for me. Mucous membranes are moist and pink. Hard palate seems to be intact. Floor of mouth looks good. Teeth are intact, nothing there. Stick your tongue out for me. Tongue looks good, symmetrical, no lesions. Stick your tongue out wide for me. And say ah. Alright. Uvula did raise, so that's a good indicator. That all checked out fine. Pharynx looked good as well. Let's see. Now we're going into the lymph nodes, okay? So lymph nodes, you want them to feel spongy and movable, okay? If you're not feeling that, then obviously you're probably not feeling the right ones. So we're going to do the pre-ocular ones, which are right in front of your ear. Alright. Post-ocular, occipital. Okay. Submandibular. Alright. Tonsillar, supraclavicular, clavicular. Alright, all that looks good. Submental and superficial cervical. Okay, all that checked out good. So we're going to go through your range of motion of your neck. I want you to do your chin to chest, please. Awesome. Turn your head side to side. Ear to shoulder, please. Good. Other one? Good deal. Extend your head backwards. Good deal. So I'm going to get you to turn your head with me putting resistance on each side of your face. Turn your head towards my hand. Good deal. Other side. Good deal. Shrug your shoulders. Good deal. All that checked out fine. Now we're going to go into the trachea and the thyroid. With the trachea, we're making sure that it's midline and symmetrical, so all that looks good. One thing about assessing the thyroid, though, guys have an Adam apple, so we use the water, so when they swallow, you're able to better feel it. So let me get back here. Alright, let me find where I'm at. Adam's apple's right here, so. Alright, go ahead and drink. Yes. Palpate it fine, didn't feel any nodules, anything like that, anything out of the ordinary. So now we're going to go into the carotid pulses. You have them on your left and right side. I'm going to feel each of them, palpate them for a regular rhythm rate, and then we'll go into listening to them for any kind of bruits, which is like a whooshing sound only heard by a stethoscope. So look straight at me. So with this, you go to the Adam's apple, about 2 little fingernail lengths past it. Alright. Alright. Now we're going to listen. With the fail side, of course. Alright, regular rate, rhythm. All that sounded great. Alright, now we're going to go into the posterior chest. Do you mind putting your feet towards this end of the bed, please, sir? Just exposing the back is what I need. So first of all, we're expecting the back for any, for symmetry, of course, making sure everything is symmetrical. Just looking, making sure there's no lesions, any kind of bumps, bruises that we need to be aware about. We're also going to assess for tactile fremus, which is when a patient says the word 99, and as you tap on their back, to test for any kind of congestion. So, all right, Sarah, I'm going to get you to say 99 over and over as I hit each part of your back with the palm of my hand, okay? All right, go ahead and start.
99, 99, 99, 99, 99, 99.
Okay, all that sounded good. Nothing out of the ordinary there. We are going to use this reflex hammer now to what we call percuss over all of the lung fields on the posterior chest. All right, you're gonna feel just like a little hit on your back, okay? Don't freak out. Okay, everything checked out fine there. Nothing out of the ordinary. Now we're going to check for what we call flank pain. Flank pain is located on the sides of the back. So I'm going to take this side of my fist and hit each kind of side of each flank, what we call, and you just tell me if you feel any pain or tenderness, okay? No pain or tenderness, noted. Good deal. Now we're going to listen to your breath sounds on your posterior chest, okay? Using the diaphragm of my stethoscope. All right, deep breath. Good. Deep breath. Good. Deep breath. Good. Another one. Good. All right, everything checked out good there. No problems there. Everything was clear. Clear bilaterally. All right, you can turn towards me now. We're going to go over the upper extremities. Upper extremities are from the waist up, okay? So first of all, we're going to inspect your arms and just slide your gown up just a little bit. Just making sure everything is symmetrical, no lesions, nodules, all that looks good. Now we're going to do your radial, brachial, and ulnar pulses, okay? We're going to start out over here with the right arm, just checking his brachial pulse. Radial. Let me pick it up. It's a little better for me to get a grip. Awesome. Okay. Alright. Everything is equal and regular, so I didn't feel anything abnormal there. Alright, now we're going to assess cap refill. Now I'm going to go ahead and let you know that there is a wound to the middle finger on the right hand due to an injury with glass. Wound care will be done later on tonight, but that is one reason why the middle finger will not be assessed during this video, okay? Other digits will indeed be assessed. Alright, so capillary refill on the right hand, we want it less than 2. Alright. Going to the left hand. Alright, everything looked good there. Everything was less than 2. Alright, now we're going to do your range of motion for your upper extremities. I want you to put your arms above your head, please. Both of them. There you go. Alright, and then hyperextend your arms to your back like that. Good deal. And then I'm going to have you abduct and adduct. So, up, down, in, out. Good deal. Everything checked out fine there. Now we're going to do your elbow. I'm going to get you to flex your elbows, extend them, hyperextend them, just your elbows. There you go. Alright, now I'm going to try to get you to flex your elbows with me putting resistance. Okay? And extend them. Good. Alright. I'm going to get you to pronate and subnate your forearm. So just Okay. All right. Now we're going to the wrist, hands, and fingers. So I want you to flex your wrists towards you. Extend. Hyperextend. All right. Make a fist with your hands. All right. Spread your fingers out. Close them. Good deal. All right. Then I want you to take your thumb and I want you to hit every finger with your thumb. Good deal. All right. Now we're going to do the cerebellar function test, where we're going to do nose, like finger to nose. Start slow, speed up, okay? Finger to nose. And then just speed up as you can. Good deal. Good. All right, that's good. Now we're going to test graphesthesia. So I'm going to draw something in the palm of your hand, and I want you to tell me what it is, okay? Close your eyes for me.
0.
Good deal.
A.
Good deal. Now we're going to test the serognosis, which is where I put an object in your hand with your eyes closed. You tell me what it is, okay? All right.
That's an ink pen.
Good deal.
That's a sock or something.
A sock?
Rag.
Sock,
Excuse me.
All right, now we're going to do your reflexes on your brachial, your triceps, biceps, and brachial. Okay? So with biceps, we're going to start on this arm. Sorry, this gown I know is aggravating. Biceps, triceps, we're going to hit back here. I want you just to kind of let your arm loose, okay? Good. Biceps, we're going to hit up in this area. Good. With the brachial, I'm going to run this down, and you should get a reaction in your fingers, okay? Good. All right, coming over to this side. Make your arm just kind of loose. Good deal. We're going to do the tricep first. Then we're going to do the bicep. Good deal. Brachial. Good deal. All right, now we're going to get you to lie down, head this way, feet this way, please. I'm going to expose just your chest, okay? So first of all, we're inspecting the chest for any kind of lesions, any kind of areas that could be concerning. While we're doing this, we're also watching the work of his breathing, making sure that it's not labored, okay? So we're inspecting the chest. Everything seems symmetrical, no lesions, patient's not having any increased work of breathing, respirations are even and unlabored at this time. So, now we're going to inspect and palpate over the pericardium. Now we're going to listen to the aortic, pulmonic, mitral, and tricuspid valves, okay? I'm going to use the bell part of my diaphragm first, making sure that we don't hear any heaves, bruits, anything like that, okay? Okay, now we're going to listen again using the diaphragm side of my stethoscope. Everything sounded great. I heard S1, S2. No abnormal heart rhythms, no murmurs noted. Now we're going to go to the abdomen. So with doing the abdomen, you never palpate first. Palpation is always last. So we are going to inspect, auscultate, and percuss before we palpate. So I'm inspecting the abdomen, making sure there's nothing abnormal, looking for symmetry as well. Making sure that there's no noticeable peristalsis. Making sure his abdomen doesn't appear distended. Or any kind of pulsation. The umbilicus is inverted, so no hernias are noted that we can see. We are going to auscultate the bowel sounds using the diaphragm part of my stethoscope. We're going to start with this right upper quadrant. Alright, right lower quadrant, left upper quadrant, left lower quadrant. Alright, we're also going to check his renal arteries and aorta using the bell side of my stethoscope. We're going to percuss all four quadrants using my reflex hammer. You're going to feel just like a little hit on your abdomen, okay?
Okay.
Alright, now we're going to start out with a light palpation, moving into a deeper palpation, starting on the right side, okay? No distension noted. Abdomen is soft, non-tender. Going into a deeper palpation. Alright, we're also going to palpate the liver. The end of his rib cage is right here. Liver is located up in this area. Right up in this area. Okay, good deal. So like I said, the order of inspecting the abdomen is you inspect, auscultate, percussion, palpate. You never want to palpate first. You don't want to have sounds there that aren't truly there. You don't want to promote any peristalsis. So, moving on. Alright, now we're going to go into the lower extremities. I'm going to cover your chest up, okay, Mr. Hall? Lower extremities, we're looking for any lesions, lumps, nodules, checking for any edema also. Looking for the tubular edema, no edema noted. Hair growth is evenly distributed. Alright. We're going to check the popliteal, posterior tibial, and dorsal pedis pulses. So popliteal is going to be behind the kneecap. Okay. Alright. Tibial. Okay. And then dorsal pedis. Okay. All right. Everything there checked out fine. No edema noted. Did you feel any pain during my palpation down your leg, around your feet?
No, ma'am.
All right, good deal. Now we're going to go into your range of motion on your hips, legs, and knee. I'm going to ask you to raise one leg at a time at a 90-degree angle. So we'll start with the right one. Good deal. Go into the left. All right. Go ahead and take your knee to your chest, please. Pull your knee into your chest. Good deal. All right. Go into the next one. Good deal. Go ahead and take your right heel and move it down your left leg. Up and down. Good. Go ahead and do the other leg, please, sir. All right. Good deal. All right. Checking your feet. I want you to point your toes towards the wall. Good. Point them back towards you. I'm going to do resistance, okay? Relax them for me. Push them towards you. All right, gas pedal. Good deal. All right, now I'm going to get you to do your knee in and out towards each other. You can do it one at a time.
Oh. Like this?
Like turn it toward, yeah, like turn it toward,
Like that?
yeah. And then other side. Okay, good deal. And then abduct and adduct your legs. Kind of like spread them and put them back in.
Like this?
And put them back in. And then take your feet, you can relax it. Take your feet and go towards each other. And then out. Good deal. All right, now we're going to go into the plantar, Achilles, and Babinski's. We'll do the patellar first. Patellar is your kneecap. So we should get, when I hit with this reflex hammer, we should get a little bit of reflex from that. Good. With the Babinski's, it should not fan out whenever I run the reflex hammer down the foot. Your foot should come like back up and not fan out, okay? All right, and then the Achilles. Good. All right. All right, Mr. Hall, you can sit back up. We are almost done.
Oh,
All right, I'm gonna get you to stand for me. I'll tie this gown up for you so it won't fall. All right, so I'm gonna get you to get right here, and we're gonna walk on your heels like this. All right, going back this way, walking on your toes. All right, hop on one leg, other leg. All right, come stand right here, feet together. Close your eyes. This is the Romberg test. There can be a little sway, but not a lot, okay? All right, let's go. Put your feet together and do it. There we go. Close your eyes. So you see the little sway, but it's not enough to be concerned. All right, you can have a seat, please, sir. Alright, I'm going to get you to stand one more time. We're going to inspect the spine, okay? Turn this way, please, so we can see everything. Palpating, inspecting. I don't feel any nodules, anything abnormal. Bend over, touch your toes for me. Alright, sit back up. I want you to bend sideways. Other side. Good. Backwards. Alright. I want you to twist your shoulders side to side.
Like this?
Mm-hmm. Good deal. Alright. That completes our physical exam. Go ahead and have a seat right here for me. We are going to go over a few things that one important part of your history I was going over is you're a diabetic type 2. So I have put together a handout on diabetes. The handout covers all types of diabetes. You've got pre-diabetics, you've got type 1, type 2, and gestational. Pre-diabetics are whenever their sugar's high, but they're not high enough to be considered a diabetic. Type 1, they typically have an autoimmune disease that attacks their pancreas, not allowing it to make insulin. Type 2 is usually insulin resistance. A lot of obese people have this problem. It's where your pancreas has so much stress on it, and it's like your body's wanting it to put out the insulin, but it can't. It's just not putting out the insulin like it should. And then you've got gestational that can occur when a mama is pregnant. So we know diabetes is a term that describes how your body turns food into energy. So a normal person, they eat the carbohydrate, it turns into sugar, sugar goes in the bloodstream, pancreas releases insulin, insulin goes in there, takes the glucose out of your bloodstream, uses it as energy, okay? Great. Diabetics, though, their pancreas is not able to function properly. They're either type 1, well, like I said, their pancreas is damaged, or they're type 2, they're insulin resistant.
Right.
So they're just not able to get that glucose out of the bloodstream. A problem with that is when the glucose cannot get put out of the bloodstream, it builds up. A lot of times people with kidney function, well, I'll go back to that in a minute. When it builds up, it can cause you to have high glucoses, which can be a life-threatening matter, and then eventually could turn you into what we call ketoacidosis, diabetic ketoacidosis.
Right.
So, I went over to pre-diabetics. Are you familiar with an A1C?
Mm-hmm.
It's a blood test. You know that we can look at your blood sugar over the course of 3 months. Doctors use that to pretty much can tell if somebody's lying or not about checking their blood sugar.
Right.
So, because you're a type 2, I'm going to focus more on my type 2 section that I put together for you. So type 2 is a non-insulin dependent diabetic. A lot of times they're on metformin, glipizide, that type thing. Pancreas makes some insulin, just not enough to do the job that it's supposed to do. So signs and symptoms of becoming a type 2 diabetic: increased thirst, frequent urination, increased hunger, fatigue. Sometimes they have unintentional weight loss, either it be weight loss or weight gain, blurred vision, slow healing sores, frequent infections, numbness, tingling, patches of dark skin in their armpits and neck. So, also, diabetic type 2s possess some of the same problems diabetic type 1 does, such as the retinopathy, neuropathy, and the kidney failure, pretty much. But diabetics type 2 also are at a greater risk for heart disease and stroke. Typically, these patients are more obese, excuse me. So, treatment, taking your medicine as prescribed, keeping a healthy diet, keeping a healthy weight. Checking your glucose is very, very important. A lot of people don't take this seriously. They end up having to get certain limbs cut off. One thing that when I look at you, I feel like I need to, hit on is your finger. You cut your finger, you're a diabetic. That's an increased risk of delayed wound healing, more increased risk of infection. If you don't keep an eye on it, do proper wound care to it, change the dressing like you're supposed to, take your antibiotics like you're supposed to, it could get to the possibility of having to get that finger cut off, point blank. So make sure that you're taking care of your diabetes, checking your sugar properly, doing your wound care, taking your antibiotics, okay? What I was going to, another thing with diabetics, which this can go, well, more so type 2. So you're on metformin or you're on glipizide. Main one, glipizide, is a long-acting medication. You're in kidney failure, you don't check your sugar, you look up, oh, my sugar's 30-something. You go eat, you check it, oh, it's went up to 84, I'm good. Not necessarily when you having glipizide in your system, it can be more prone to drop your sugar and you don't even know it. All of a sudden you think you're fine, all of a sudden you done hit the floor and passed out because your sugars done went back down to 20.
Right.
So main thing is making sure you're checking your sugar 2 times a day, day and night, taking medications as prescribed, watching your body for any type of sores. Neuropathy is a big thing with diabetics. If you have tingling, numbness in your extremities. I'm trying to think of anything else I need to hit on. make sure I'm not forgetting anything. Main thing is try to change your diet styles as well. Incorporate better foods, more greens too. That way, because if you can get weight off your body, it doesn't make your body work as hard to produce the insulin. So, do you have any questions or concerns?
No, ma'am. I'm good.
All right, well, this concludes our physical assessment and teaching. Thank you for joining us.